Good afternoon, everyone. This is Justin Rush and Carlos De Leon from NASTAD. We definitely want to say thank you so much for joining us today for this webinar, Using the Sexual Health Model as a Blueprint for Appropriate Care in Serving Black Gay Men. This is actually the last iteration of this series. It started off in November with practicing cultural responsiveness in healthcare delivery settings, and we now are completing this session of series of webinars today talking about the sexual health model as a blueprint for appropriate care in serving Black gay men. This is actually one of the last few things that I will do as the Nicholas A. Rango Fellow here. It has been a 2-year appointment here at NASTAD, and I have absolutely enjoyed my time as the Nicholas Rango Fellow, providing direct technical assistance to health departments on issues pertaining to Black gay men. So I definitely want to say thank you so much for that, and thank you for joining me in these webinars. I also want to say I do apologize for the back and forth with the email and the miscommunication about having your invitation declined, and again, thank you so much for being with us here today. So just a couple of webinar overview, and we're going to do some housekeeping things. And just of note, I am still planning on being at NASTAD. I just won't be the Nicholas Rango Fellow anymore. But I still have every intention of remaining at NASTAD and working with you all in the future. So just to provide a little bit of a webinar overview, we're going to talk about laying the groundwork, what we've learned from the Center for Engaging Black Gay Men Across the Care Continuum, which is our cooperative agreement with the Health Resources and Services Administration. Some of the deliverables that are going to come out of that. We're going to revisit cultural responsiveness and some key takeaways from that webinar. I'm going to talk about some of the current challenges for Black gay men in HIV prevention. We're going to move on to sexual health and the sexual health model, provide a little bit of an introduction in regards to the key points and facets of that theory and model, and we're going to then move on to some considerations before implementation, talking about expectation management and cultural responsiveness and what they play, how they play and factor into the implementation of the sexual health model. I'm going to have a conversation around culture and HIV prevention intervention strategies, and I will actually get to talk about something that I'm very passionate about and a deliverable that has spawned from the Center for Engaging Black MSM Across the Care Continuum, which is the RAW, the Real Authentic Words web series that will be making its debut in July of this year, which we hope moving forward will be a resource that health departments and service providers can use moving forward as a tool to engage and provide better care for Black MSM. So more information about that to come. And then we'll have a Q&A section at the end. So just a little bit of webinar etiquette. We have the fabulous and wonderfully talented Carlos De Leon that is serving as a co-presenter on this presentation. He will be taking any questions in the chat box down in your bottom left-hand corner. Everyone is currently on mute right now, but if you would like to unmute your phone, then you would need to press *7. All verbal questions are going to be held until the Q&A section at the end. Hopefully I can address any questions, comments, and concerns that you have then. And like I said, written questions and comments can be taken either directly to me on the bottom left-hand corner in the chat box, or you can send those to the entire group, and Carlos will be diligently working throughout the webinar to address those questions. So in moving forward, this is really definitely just kind of a revisit to some of the things that we've discussed these next few slides. But our cooperative agreement with HRSA to develop the CBAC, which is the Center for Engaging Black MSM Across the Care Continuum, this really was the impetus for a lot of this work and the webinar that we constructed on cultural responsiveness. So the key goals of that Center for Engaging Black MSM Across the Care Continuum was to describe healthcare challenges for Black MSM, to address misinformation, knowledge gaps, and ignorance among provider communities, and to develop skills in offering high-quality and nuanced, culturally responsive sexual health services. So those are the primary goals. And then as part of the Center for Engaging Black MSM Across the Care Continuum, what we initially did was Amor Amoyge, our Associate Director of Health Equity, who's the project director over the CBAC, hosted a number of different focus groups all across the country, providers and Black MSM, to figure out what some of the needs are on both ends. And across the board, we received 5 major points and key takeaways from that data. So patient and provider priorities and communications are out of sync, and that's something that creates some dissonance within providers and some dissonance within Black MSM as well. So there doesn't seem to be this thorough thread of communication that's working, and that therefore is having negatively impacting Black and gay men's ability to successfully navigate the care continuum. Two, Black MSM are resilient. So in situations where we're not able to necessarily receive what we need within healthcare delivery settings or within our immediate families, we are building our own support systems outside of our traditional family structures. Three, Black MSM are certainly seeking out providers where they can build positive and affirming relationships. So this is something, and moving forward, we are creating a provider directory as part of the CBAC. So we would ideally like for Black MSM to be able to go onto the CBAC website, to click on their state, and to hopefully find a provider that we have deemed culturally responsive and someone who has a history of providing PrEP or prescribing PrEP to their patients and has a history of having a good working relationship with their patients, because that's something that's very important for Black MSM, not just for them to be able to successfully navigate the healthcare system, but also just it's good to harbor great relationships between patients and providers alike. And four, there's stigma across the board, so whether it's in healthcare delivery settings, within churches, within day-to-day life, stigmatizing language exists around HIV, sex, and sexuality, and that is certainly prevalent. And stigma, as we know, the bar before the bars, NASAT has been speaking about this for years now, impacts one's ability to get linked to care and get antiretroviral therapy and to become virally suppressed. And five, it's very important that we develop meaningful relationships with patients. That's something that matters. It's something that matters to providers, and that's something that is really kind of the biggest theme or motif as we take away from what the focus groups have been saying and what the CBAC is focused on. The Center for Engaging Black MSM Across the Care Continuum is all about providing continuing medical education credits, continuing nursing education credits, and helping providers learn more about the Black MSM experience, what some key barriers are to successful navigation of the healthcare delivery system, and what they can be doing to usher in a new day as it pertains to HIV prevention, treatment, and care. So again, really want to hit home that cultural competency is something that's great. It's something that we'll never say is not something that one should achieve or to strive to. But if we're thinking about the minimum set of standards, cultural competency is down kind of like the lower end of the spectrum. We want people to think of this as a lifelong learner model, that you'll never be too competent in one's culture. You can't necessarily receive a certificate and therefore be competent in one's culture. That's something that we've been trying to hit over the head throughout the entirety of this series, and I think that it's kind of been received in a mixed way. But we understand that it's important for people to focus on the issues that are being brought to them right there in the doctor's office, right there in the health department, thinking about critically the socio-political, economic issues that are affecting Black MSM, checking privilege, engaging in expectation management, and then helping Black MSM engage into a course of care that works best for them, and then go from there and operate within that specific course of care. So this is just kind of an image or an infographic of cultural responsiveness in motion. This is something that, in moving forward, the slides should all be sent to you at the end of this webinar, but also this can be found on our website, nasad.org. But again, addressing the healthcare need involves a number of different steps and should be repeated constantly. It's an ongoing input and output process. We want people to be engaging in introspection, expectation management, dialoguing, and dual disclosures, which is where the importance of trust is so very important, engaging a patient into a course of care, assessing if that course of care is the best for that patient, and then doing a care re-engagement to ultimately address the healthcare need. So this all brings us to what is sexual health, and it's for a group of individuals that I feel like are probably pretty literate in HIV and public health. This may seem like a silly question, but we really want to think about sexual health as an individual is sexually healthy when they have accurate knowledge, accurate knowledge of the things that are impacting them, accurate knowledge of their health, their broader health. We want them to have personal awareness. We want them to have self-acceptance. We want them to have value and emotional congruence. So we want their values and their emotional stability to kind of match. And we also want them to have the ability to communicate. So an individual that has sexual health is someone that can communicate, whether it's disclosures before sex or after sex or before intimacy. We also want individuals to be able to communicate adequately to their provider. This is what's going on. This is the type of sex that I'm having. This is who I'm having it with, and this is how frequently that I'm having it. This is what I need your help with to help me kind of understand what the best course of care is for me. And so in thinking about what the current challenges are to ensuring that an individual is sexually healthy, there's a number of different things at play, and it's not just stigma. So the first of them, one of them is adaptive duality. So we're thinking about this is also can be considered role flexing. Some people refer to this as code switching. We're gonna do a deeper dive in just a second, but this is essentially a coping strategy that has been witnessed and evidenced among Black people, where the speech and behavior and dress shifts and changes depending on the audience. We also have to have a conversation about self-efficacy, one's ability to make strong and consistent and healthy decisions for themselves, and their feelings of are they able to make those decisions successfully? Are they able to make them make the best decisions for them? We have to address the fact that when we're thinking about Black people in communication, typically there are indirect patterns of communication that goes back to that has implications. Well, not implications. That is rooted in slavery. So we're going to unpack some of that there, and then we have to also talk about some of the mistrust of providers. So these are all things that are kind of impacting one's ability to successfully navigate the care continuum. And I see a couple of questions coming up in the question box. Carlos, if you could try to address those. I think Nestor has a question, and if not, then we're going to try to answer those once we get to the end. So thinking about adaptive duality, again, this is something that's considered almost like role flexing, or some people call it code switching. So it's a coping strategy where African American speech, behavior, and dress frequently shifts and changes dynamics to appear acceptable to the group with whom they are interacting with. So historically in the presence of, quote-unquote, the oppressors, or someone who is coming from a power, when the power dynamic is off, or someone who is considered to be kind of a leader or an authority figure, it's not uncommon for Black people to display verbal patterns that are submissive in behavior, and then to to kind of submit to the authority figure that is present. The authority figure can often be the provider. So that's something that can potentially stand in the way if you're not taking into account the cultural nuances of the Black experience a lot of times. And that's not to say that it's monolithic, but for a lot of people, it's been evidenced that culture shifting, adaptive duality, role flexing, code switching, is a barrier and a roadblock into getting the successful information that a provider needs to be able to come up with the strategy for the course of care. So this idea that I'm having a conversation with someone who is very well degreed, who's very well educated, probably makes a lot more money than me, I probably need to shift my speech and behavior and maybe even my dress to kind of figure out what's most comfortable for them and present myself in a way that's most acceptable to them, and that may not necessarily include the real and accurate disclosures of my sex or my experience. So that's kind of what we mean when we say adaptive duality, and adaptive duality can be a barrier for enrolling someone into the proper course of care. We also have to think about self-efficacy. So external factors influence that. So oh, I'm sorry. Just to touch on this, because this is a really great example. I put stars all around this. So an example of role flexing is this concept of Black masculinity, right? So the African American community, the Black community, has, in a way, adopted this motif or idea of a male often characterized by the swagger in their walk, physical agility, and posturing, quote-unquote, being tough and having sexual confidence with women. This is something that's encouraged from a very early age within our community and throughout our life. Men are also expected to provide for, protect, and nurture immediate and extended family members, especially in the absence of other men. So this idea or this trope of black masculinity often is walking into doctors' offices and standing as a barrier in the way of being able to say, this is what's affecting me. I may have a wart in my anal cavity. How do I have a conversation about that when that doesn't necessarily fall within the strict, rigid confines of black masculinity? So thinking about adaptive duality and thinking about how an individual may then shift their responses to a sexual history taking based on what's acceptable to the authority figure, that's an example of what we're talking about when we're speaking about adaptive duality. So we have to have a conversation around self-efficacy as well. So essentially there are external factors that can influence one's personal control. So among African Americans, there's been the religious, the gender, the culture norms that reinforce deference to perceived authority figures and valuing oneself after others. So when thinking about if one feels like they are empowered to be able to go into a doctor's office and say, this is what's affecting me, this is the type of sex that I'm having, these are the types of questions that I have, that might fall outside of the rigid religious, gender, and cultural norms within the black community. And so that is an example of a barrier of getting someone enrolled into the proper course of care. We also have to think about communication and mistrust of providers. So when we're thinking about historically that there's been this assumption that HIV prevention requires clear, assertive skills for self-protection, verbal communication between partners to minimize risky practices and condom use. It's just assumed that individuals will have those tools in their toolbox to be able to use them. But among black people traditionally, patterns of indirect communication were established because direct interactions were specifically prohibited during slavery. So I'm going to just let that statement sit and let people ruminate with that. But we are not that far removed from slavery, and I know nobody really feels comfortable talking about it, and I know no one here that living today was a slave or owned slave, and I think that that's a perfectly valid statement. However, I think that there are some long-standing traditions and some long-standing effects of that system that remain with us today, and because of the fact that direct interactions were prohibited during slavery, as a result, many black people and many black communities created elaborate codes of communication through music and nonverbal body language that don't necessarily translate well when it comes to going to a doctor's office and having those quote-unquote real kind of tough conversations with one's doctor. When it comes to sex, communicating directly and disclosing sensitive sexual information may contradict with African American culture and religious values about modesty, and that modesty that's promoted by families. When we're also thinking about mistrust of providers, so I know people hear all the time, Tuskegee, 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 but there's also a very real healthy paranoia or suspicion of the intent of unknown persons until they demonstrate their honesty and trustworthiness. This is something that has been evidenced in communication patterns as it pertains to black people. It's one of the most commonly used protective coping strategies that promotes disbelief and mistrust. So we're thinking about all of these things, and we hear people talk all the time in the realm of public health about the social determinants of health. The social determinants of health are very real, but I think that we talk about them from a very kind of 30,000-foot view. We think about them from a highly theoretical standpoint. And one thing that the sexual health model really does try to infuse into our HIV prevention treatment and care programs is this idea of culture, cultural nuances as it pertains to black people, and how knowledge of that culture and those cultural nuances can be used and infused to create comprehensive and holistic care and treatment programs for black gay men. And finally, the ability to communicate explicitly about sexual needs is important, and it's something that, again, getting back to the indirect modes of communication, people may not necessarily have the tools that they need to be able to share the information that they share. I've heard so many times in so many spaces, I'm trying to ask the questions, I'm trying to get the information, but there's a disconnect. I think that it's hard for a group of people that are the marginalized of the marginalized to be able to adequately communicate, to operate from a system of power when it comes to walking into a doctor's office, to be able to set appropriate sexual boundaries, and also to be able to be free from sexual dysfunction and adequately communicate explicitly to their provider their needs. And so this all brings us to an alternative model slightly to HIV prevention. Unfortunately, I really did a lot of work of trying to get Dr. Gail Wyatt. She is the professor of Department of Psychiatry and Biobehavioral Sciences. She's also the director of UCLA Sexual Health Program and the associate director of UCLA AIDS Institute. The sexual health model as a framework for innovative HIV prevention strategies is something that she came up with, and I tried really, really, really hard to get her onto this webinar today. Apparently she's very popular and very booked because I wasn't able to land that, but I was given a license to speak about her model and how it can pertain to appropriate care and treatment for Black gay men. So the three nuggets that are basically within the sexual health model is a focus on interconnectedness, sexual ownership, body awareness. So a lot of talk and conversation about sex positivity, a lot of talk and conversation about meeting people where they are and operating within the constraints of where they are and then going from there to create an appropriate course of care. And like I said, we're going to unpack all of that in just a second, and we're going to talk about some considerations to think about before trying to implement a sexual health model or an intervention strategy that is rooted in the sexual health model. So more information about the core principles of the sexual health model. Interconnectedness stems from this common belief that we have as a society in general that being in a relationship and having a family defines one's identity or shapes one's identity and enhances personal value. So to take it a step further, Dr. Wyatt acknowledges these beliefs, but also emphasizes that personal health, along with family ties and social networks, is an important component of interconnectedness regardless of relationship status. Sexual ownership. So this is owning one's sexuality. This is where the conversation around sex positivity and meeting people where they are comes into play. So if an individual does get to the point to where they feel comfortable enough to have real disclosures, honest disclosures with you about their sexual history during the sexual history taking, and them saying that I am an individual that is a top and I typically like to have condomless sex, I typically like to have raw sex, what is it that I should know and what is it that I should be doing to help protect myself? Sexual ownership is all about being responsible for one's sexual and physical health, and it's not about judgment. It's about checking those biases at the door and saying, well, since you are a top who loves to have condomless sex, let's think about possibly getting you on PrEP. Are you using condoms at least some of the time? Are you getting tested regularly for STDs and HIV? So that sexual ownership, through the sexual health model, sexual ownership also promotes skills to enhance personal control as one learns to assess risky people, risky behaviors, and risky circumstances. So it's all kind of like harm reduction in a sense. So it's meeting people where they are, it's operating within their very real circumstances, and then going from there to engage them into the appropriate course of care. And then we have body awareness, and this can often be limited by cultural and religious prohibitions about body touching, condom usage, contraceptive use, and certain sexual practices. And the sexual health model provides knowledge about how the body works, diet and exercise for a healthy body image, mind and body health, which I feel like is something that has been so sorely left out of HIV prevention and treatment programming, is this focus on mental health. But mind and body health and skills needed to identify and articulate problems that require treatment. So I think that the point here is that if we're thinking about, we say that we want to be holistic, we want to provide more holistic care to Black and Latino MSM, that you have to take more into circumstances of, condoms. Everybody's not necessarily going to be a purveyor of condoms, and I think that this is a perfect opportunity because this will be the only time that I will mention this. Is the CDC's report that half of Black gay men and a quarter of Latino MSM are projected to have a lifetime risk of HIV. I think that at this point in time, we really do have to get a little bit innovative and be a little bit different when it concerns the type of care and treatment that we're going to be providing. I know we have the Mandate program, we have 3MV. These are two programs that are getting to the heart of providing holistic care for Black and for Black MSM. But I think that at this point, we are really going to have to rethink our approach and seriously convene and think about what it is that we can be doing to provide the most holistic care for Black MSM. And so just a few points before we get into the implementation or talk about what the implementation of that sexual health model can look like. We have to, again, think about the barriers to achieving viral suppression. So we have to think about the bar before the bars. We have to talk about the racism. We have to accept that homophobia and marginalization exist. Many of the Black MSM that are coming to your office are dealing with shame and poverty, have dealt with early childhood sexual abuse, have been cast out from their family, have a lack of insurance, have a lack of health insurance literacy, and are often dealing with provider bias. And I think that before you can even engage in trying to use the sexual health model as a guide for appropriate care for Black MSM, if you are not accepting these things, if you are not actively thinking about these things or having conversations about these things as a staff and what you can be doing to increase insurance literacy or overcome provider bias or overcome racism within your institution, then I think that has to definitely be the first step before you can even engage in this work. And then you also have to, again, we've talked about this before, expectation management. So you have to manage your expectations, and you have to try to manage the expectations of your patients. So knowledge of the mistrust concerning providers. You have to understand that there may likely be previous negative healthcare experiences that have very little to do with you, but you will actually have to work within and actively work towards to get past. You have to do the myth busting beforehand. So you have to understand that while there is no monolithic experience, that you have to be respectful and responsive to the individual's culture, and you have to understand the power dynamics at play. You are someone who is seen as an authority figure, and therefore those power dynamics can inform the way that an individual interacts with you in a healthcare setting. And again, we all have privilege. I have a privilege because of the fact that I always had Blue Cross Blue Shield insurance my entire life. Even though I was Black and gay and was living in Mississippi, that was still a privilege that I have. Again, you have to be able to think about the racism and the provider bias and the lack of access, and you have to be able to check your privilege at the door before you can even try to engage in this work of rolling out the sexual health model. So just a few examples of what can be done to kind of infuse interconnectedness, body awareness, and sexual ownership into your intervention strategies. And adaptive duality can be addressed by teaching individuals the skills needed to align their risk reduction efforts with their behavior. So whatever their sexual orientation is or their culture-derived role in a relationship or family. You can try to help provide advocacy skills to involve testing for HIV and sexually transmitted diseases, social support, and treatment. And regardless of whether individuals fully disclose their behavior to sexual partners, you can try to push an open discussion of past and current sexual experiences with health and mental health providers. That is essential. To address some of those external factors and try to get to helping an individual have higher self-efficacy, you can influence those external factors by pushing for personal control. So pushing this idea that an individual can identify and discuss the effects of their past experiences and relationships in which someone else controlled them. So this gets to the heart of interconnectedness and sexual ownership, and help them prioritize those in the future where personal control is essential. And then there are also methods of self-protection that minimize power struggles in relationships. These are things that can be adapted to help push for sexual ownership. Again, interconnectedness and focusing on the social networks. I know in Tennessee, the Tennessee Department of Health has had a lot of success in utilizing the social network strategy to help get Black MSM tested within their jurisdiction. And that's something that I know that they have had a lot of success in ramping up their Black MSM work. So again, this idea that Black gay men are interconnected, and they need to have sexual ownership. We need to help them push for body awareness, because this is a holistic care, and we want them to be a whole person. It's not just HIV that they're dealing with. They're dealing with housing issues. They're dealing with stigma. We are dealing with racism within our community and abound. So these are all things that have to be considered. And one thing, key takeaway from the sexual health model, is culture and the HIV prevention intervention strategies. So this is probably one of the biggest things that we've been talking about throughout this entire series, is that you have to infuse culture within your HIV prevention intervention strategies. So one of the key takeaways from the sexual health model is that you really should be trying to actively use modes of communication or methods of communication to disseminate information within the community, so within Black MSM, amongst Black MSM, by Black MSM, and through new and inventive channels. So the use of new media, the use of videos to disseminate information, key information in an intelligible yet entertaining way. These are that in an intelligible and entertaining way, but also that is reflective of the community that they're speaking about. This was something that was very important to us, and this is something that we marked a star by. So if we're thinking about infusing culture into HIV prevention intervention strategies, as a team, when we were going through CBAC and thinking about what our deliverables were going to be, we said we had a really great idea, and the light bulb just kind of went off. And this leads us to the big kind of resource that you all will have moving forward that will help to infuse culture in your HIV prevention intervention strategies. Because I know the question is from you all is that all of this sounds really nice and it sounds really great and theoretical, but what can we be doing programming-wise to help implement this? And here's where the idea behind the RAW came from. This is the Real Authentic Words. And it's a web series, essentially. It's a 6-part web series that we're going to be rolling out in July. And the purpose is to serve as an online platform for Black gay men to access educational and entertaining information. So again, this is the idea that came up from the sexual health model. So having conversations around interconnectedness, body awareness, and sexual ownership, how can you do that in a new and innovative and educational yet entertaining way? How do you disseminate key information to the community without hitting them over the head with statistics? That was one of the first things that we said as a team, and Blake Rowley, who is the former Nicholas Rango fellow, is going to talk about in just a little bit about the impetus behind the idea. But we were so sick and tired of hearing the statistics, so sick and tired of hearing the crisis, which hearing the crisis is very important, but it's kind of like, so what are we going to do next? Yes, we understand the epidemiological data, but Black gay men are tired of being told that they are vectors of disease. So how do we provide personal experiences as an educational tool for providers and for Black MSM to disseminate key health policy and biomedical intervention information in a way that infuses in our culture, is representative of the community, is for us and by us, and is all about interconnectedness and sexual awareness and body awareness, and sexual ownership, That was the question. And when we were thinking about how and what our deliverable could look like, we came up with the Real Authentic Words, a web series. So the overarching goal of this web series are to increase health-seeking behaviors among Black MSM with a focus on those 18 to 30. That's really kind of, it seems a little bit rigid, but, this is 18 and below, 30 and below. I think that once you all see this, and we're very excited to debut this, once you all see the material, you see that this is transformative, that it goes beyond a generation gap, and that we're having conversations about things that young and older Black MSM alike are having conversations about. We wanted to provide Black gay men with resources to be advocates for their own health, and we wanted to foster healthier relationships not only amongst Black gay men, but we also wanted to have foster better relationships between patients and providers. And so The really great thing about this is that we were sitting at brunch one day, myself and some friends. We try to meet up once a month to talk about life, love, sex, and relationships as Black gay men. Some of us work in the HIV field, some of us don't. But it's really just an opportunity just for us to kind of talk and be ourselves and let down our hair and just be crazy with it. And we were having a conversation one day over brunch, over mimosas naturally. And we were having this heated debate and heated conversation about racism within our community. And I think in the mimosa haze, I looked over at Blake, and he said to me that this is the conversations that need to be heard. These are the conversations that need to be shared. These are the conversations that need to be workshopped. And these are the things that health departments and providers should be knowledgeable about, and they should be able to help Black gay men workshop through. So just a little bit of a trajectory around some of what the topics are. We're going to be talking about HIV linkage and retention and care, and it won't be that rigid, but we had to kind of package it that way for our federal partners, make sure that we're obviously talking about HIV linkage, retention, and care. We're going to be talking about sex, drugs, and the party culture, so that brings into bear a sexual awareness, and is one sexually aware, and is one sexually healthy, and what does that look like? So again, getting back to the sexual health model. Black, gay, religion, and spirituality. So talking about the interconnectedness of our communities and how woven into our communities religion and spirituality is and what that means for us as Black gay men. Having a conversation about biomedical interventions. Are we sexually aware? Are we knowledgeable of what's forthcoming? And do we have the tools necessary to be able to share our sex information and sexual histories with our providers? Having a conversation about mental health and the adaptive duality that Black people often use, so that role flexing of, it's not necessarily particularly quote-unquote Black to sit up and have a conversation about your mental health. It's not necessarily quote-unquote typical to the Black experience for one to say that I am suffering from mental health. This is something that I'm struggling with. I go and see a therapist. You may or may not be deemed as crazy by the community at large. And so that's a conversation about the adaptive duality we often have as Black gay men, is this fine line of addressing your mental health needs and being healthy as a person and mentally and physically, and also remaining true to the quote-unquote Black experience. And the final episode will be just a collection of voices and perspectives of Black gay men. So this is where Blake is going to actually come into the conversation, because we didn't want to just release a number of videos and just have them be out into the ethos. We wanted to think about how can health departments workshop and get through these topics, because it can be a little bit difficult to talk about. There may be some tears. But we wanted to create a curriculum, and some people are referring to it as an intervention strategy. We're not specifically saying it's an intervention, but I'm going to kick it over to Blake to talk about the web series, the videos, and what the future of this resource will mean for health departments and providers as a curriculum, and talking about it and workshopping through it.
Thanks so much for that, Justin. As he said, my name is Blake Rowley. I currently work at NASTAD. So the curriculum is really designed to provide people with the opportunity to engage primarily young Black MSM, but really you sort of use a swath of Black MSM across ages, and to engage them in a new way. So what we wanted to do, as we created the video, as Justin mentioned, we felt that we didn't want to just have a single or stagnant resource, i.e. the video. We wanted people to engage around them. So what we created was essentially a series, or what we're creating since it's not completed, are a series of guided and facilitated conversations that individuals can convene, 8 to 10 Black gay men together to talk about many of the issues that we talk about in the video. They're not actively sort of just sitting there. They engage in a variety of activities around how to build strength or awareness around things like pre-exposure prophylaxis. What is that going to mean for your life? What does it mean to talk about your race in the context of a relationship? and how do you develop those skills to be okay with having that conversation? As he mentioned, we have some harder-hitting conversations, i.e. the substance abuse and mental health pieces, and we really want, since we know that black men who have sex with men, and particularly young black men who have sex with men, don't engage in a robust and often honest conversation around substance use and mental health, and it's something that many of us have had an experience with. We wanted to, one, show individuals that there are individuals who look just like them, who also go through this experience and talk about it amongst their friends, but then also provide them with a forum and an opportunity to have that conversation, as well as to develop some of the skill sets around what it means to have that conversation, not only amongst your friends, but also with providers and practitioners who can help navigate you towards services that may help you better deal with your mental health or substance use issues that are going on. So there's also, in conjunction with that, a companion document that allows health departments to see exactly what it means to put on this type of production and this type of run of show that is being created, from cost to staff that will be needed for all of the myriad activities that will happen in the curriculum. We stress the importance of having and making sure that for all sessions that will occur, that there are mental health people on staff, and I think as health departments pick this up, NASTAT will definitely be instrumental in providing technical assistance around what type of staff members are needed, what type of place is going to be needed to this. We're currently in the process of working with some really excellent facilitators and master trainers across the country who are helping us to flesh out this curriculum and make sure that it can be as strong as it can be. I think the reason we're steering away from the term intervention is we're not necessarily looking to change people's behavior. We really want people to have a space and a forum where they can get together and have a different type of conversation. So that's the primary impetus for this. Additionally, we're also considering creating a sort of curriculum light where that's not necessarily as structured or facilitated of a conversation, where individuals can literally do the same exact thing that Justin and myself did and get together at brunch and have a semi-structured conversation. I think we want to be able to provide a number of opportunities and ways in which people can engage on this topic. Our hope is that it will be disseminated widely and that we can begin to change the paradigm and conversations that black men are having that are sort of less disease specific. We really want to encourage people to think outside of HIV, and I think the RAW really does that in terms of thinking about the number of experiences that we go through in our lifetime that impact our risk for HIV, yes, but also just impact our general health and well-being. So we really wanted to create something that was holistic and as comprehensive as we could be. So I think that sort of covers the gist of the RAW. I'm going to hand it back to Justin.
Yeah, and I definitely want to pick up where Blake left off. Again, hitting home that this is going to be a technical assistance request moving forward. So just like NASTAD takes technical assistance in regards to health systems integration, policy and legislative affairs, HIV prevention, we want you all to be able to come to us and say, we want to have an intervention strategy, or we want to have a strategy to engage Black MSM in a nuanced way that's thinking about the specific cultural aspects or things that you all go through and talk about your experiences, and we want to be able to workshop through that with a group of Black MSM within our jurisdiction. We might ideally want to have our own web series that's reflective of, say, an Arkansas or a New York or a Mississippi, but these are conversations that are dynamic. These are conversations around body awareness, sexual ownership, and sex positivities that we really need to have in our jurisdiction. Help us put that on. Help us, find individuals within the jurisdiction that would be best suited to be representatives for this project. And then also, if you just want to take the 6 videos that we have, we're going to release a video every 2 weeks, and you want to sit down and you want to get a group of 10 to 15 individuals and you want to lay the groundwork and you want to say, this is a video, this is a story. And we get really down and dirty. I've personally dealt with some of us have dealt with sex addiction, some of us have dealt with drug use, and, I think that people see us every single day. People see us in our work, and they don't understand that we are still people. Some of us have been raped. Some of us have gone through a lot of different things, but we're not talking about these things, and we're not talking about how that makes us feel about ourselves, and we're not talking about how that makes us think about our self-efficacy, and we're not talking about how that affects our ability to successfully navigate the healthcare delivery system. And we want to take this as an opportunity to control our narrative, to shape our own narrative, because I feel like it's very monolithic in television, and we want to be able to say, we are Black gay men just like you. We go through the same things just like you. Let's sit down and talk about them. Let's sit down and see and work through how we can help you become sexually positive, how you can be body aware, how can you work on your interconnectedness. Maybe the interconnectedness can be built and strengthened through the workshopping of the videos, but this is just really an opportunity for us to control and shape our own narrative and to help health departments take up the sometimes difficult task of engaging with a community that doesn't really necessarily feel very trustworthy of the healthcare delivery system. So I think that with that said, we have come to kind of the question and answer portion of this presentation. I'm seeing a lot of comments. I'm seeing a couple of comments. So this is very exciting. This was very exciting for us. We literally came up with this idea for the project about a year and a half ago, and it's been a grueling task of coming up with production and coming up with budgets and getting people there and hair and makeup and putting all of this together, putting it together an entire show. But the conversations are so rich, and everybody just has such an amazing perspective. We have some Black gay men that are going to be in the episode about religion and spirituality that are actually young Black pastors and what that's like and how they work through the stigma that they experience in churches, and how it can be hard to be interconnected when you are considered an outlier within your community. It's just we really unpack a lot of things, and I want to say thank you all so much for the positive feedback. I see a question from Craig Washington. It says, to that end, what measures, approaches will be used to engender trust and a sense of safety among participants, particularly in the initial session? So do you want to talk about that, Blake? So the question is this is exciting given the attention given to interconnectedness in relationships. To that end, what measures, approaches will be used to engender trust and a sense of safety among participants, particularly the initial session?
Thanks so much for that question. So as I said, we're working with a lot of really great facilitators and trainers from across the country who have worked on a number of CDC interventions. And so some of the things that we're doing are we definitely want to make sure that participants trust the facilitators and feel a sense of safety and are safe in the space that is created. In terms of activities that are going to be, I guess, utilized, if you've ever run any type of empowerment program, a significant chunk of time in the first sort of session is dedicated to creating that space. And so we purposefully chose a subject matter that was a little bit lighter in content so that participants could feel more open, connecting with one another as well as a facilitator, and begin to develop and build that space. So as the curriculum unfolds, the episodes do get heavier in terms of topic. So ideally, by the time you get to substance abuse, it won't be your first time meeting any of these people, and you'll feel safe and connected with them. We definitely want to make sure that participants have a space if they feel that they can talk about their personal experiences, but we want them to not necessarily. We don't want to rip Band-Aids off of individuals that we cannot put back together. So we want people to sort of engage in a critical conversation that may evoke some personal response, but however is not hinged on their personal life stories. So I hope that answers the question that was at hand.
Yes, and I see we have a couple of questions. I see Joshua Thomas has his hand raised. So Joshua, if you want to take your phone off mute, just press *7 and you can go ahead and ask your question. And I see Timothy has a question as well. Hello? So if you would like to ask a question, just press *7, and we'll either press *7 and you can ask it there, or you can type it into the chat box.
Can you hear me,
Hi, my name is Timothy Webb.
Yes.
And the question I would like to ask is, how you doing? I want to say, first of all, thank you guys, because I think this is very brilliant, and I think it's something that's very much needed. The question I have is, how do we bring this to, like, you guys have the floor mat, but how do we bring it to a large audience of people, and what's the cost associated with doing these type of different events? Do you guys have funding already identified, or with the people who want to help put this event on, or this talk back on, do they have to identify the funds?
So that's a great question. So we had set funds from HRSA to do this. However, one of the things that we felt that was really important was the ability to provide people with information on how to recreate this themselves. So Justin has created a companion curriculum that has an implementation strategy that includes everything from dollar amount. If you wanted to do exactly what we did, there's sort of the dollar figure associated with that. But then we've also worked with some other people who have done similar things to sort of really narrow down if you wanted to do like an iPhone version of it or something that was a little bit less or lower threshold. We definitely have technical assistance tools that we can provide to help assist with that. In terms of bringing it to scale for a larger audience, I think one of the things that we've used in the past has definitely been our ability to convene, as well as our ability to disseminate at conferences like NASM or the United States Conference on AIDS or the National HIV Prevention Conference. So we utilize those opportunities to sort of spark and incite a larger national conversation, as well as to disseminate. However, we're really open and willing to helping health departments identify funds, whether they be through funding announcements, i.e. 12201, or whatever the new CDC announcement may be, how to use some of those funds to do something similar, or for writing grants and things of that nature. In terms of how CBOs can use it, we would still work with CBOs, although our primary stakeholders are health departments. So when you see sort of the full package, I think you'll have a better understanding of dollars associated with things and how to proceed, move forward.
Okay, so are you going to be mailing out the full package to everybody? Because I work for AOS, was an AIDS Organization Association, and underneath that umbrella, there's several, let's say, MSM advocacy groups that I think that can really, really benefit from the information that the health departments may not be able to have that stronghold or either that reach to get to. So I'm just, when I say a broader community, I'm talking about like these specific groups of people or pockets of MSM men that pretty much frequent either like, let's say, like a Evolutions or an Impulse group or something like that that's within these geographic regions. So I'm just trying to figure out how can we take that a step beyond just the health departments and also give opportunity for a real reach within communities.
So to answer your question, all of this will be housed on our CBAC website. So there will be two websites. One will be specifically for providers, and then the second one will be specifically for Black MSM. That will be housed, so along with the continuing medical education workshops and information and continuing nursing education workshops and information, all of that stuff will be free. It will be housed online. Our part of this is meant to have this really strong dissemination strategy. So we have an entire marketing strategy in how to make sure this has the broadest reach as possible, make sure that we're reaching out to traditional media outlets and non-traditional media outlets, and also to make sure that we hit on the nail on the head by saying that this is available, this is a resource that we're having. We're not saying that you have to pay for us to get it. It will be housed on our website, and everyone will have full access to that, and we are trying to work very diligently to make sure that the dissemination strategy includes letting individuals know that it's not just for health departments, it's for CBOs and ASOs as well. We want you all to have this, and if you want technical assistance in regards to it, then that's when you would probably need to reach out to us NASDAQ staff to receive that TA around that, but it will be readily available in July when we release the videos.
Okay, well, I'm definitely interested in one, looking over the videos, and two, implementing it some type of way in Atlanta, Georgia.
Okay.
But I would like to definitely talk over with my other counterparts and things like that, just to make sure that this is on the right track, which I truly feel and believe that it is.
All right, well, that sounds good. Well, we definitely will be interested in having a conversation around how we can help work with you to roll that out into Atlanta. So thank you so much for your question. I see Joshua. I think I heard you talking at one point, but if you want to go ahead and say your Joshua Thomas, you can go ahead and say your comment or question.
Can you hear me, Justin?
I can hear you.
Awesome. I'd like to ask your opinion on how to engage healthcare providers in ways to overcome the barriers to HIV prevention amongst communities of gay and bisexual black men. Because the health department is a little bit more apt to kind of jumping on board and accepting some of these tactics to overcome these barriers. But when you take it to the provider side, they're a little bit more hesitant, a little bit different of a breed than the actual health department workers who work with communities in a little bit of a different way. If you could touch on that, that'd be really helpful.
Sure. So I think that a lot of that work is going to have to be done by us as an organization, and we've been ruminating about that a lot lately. So as the chief representatives of health departments within the AIDS directors within the 50 states and 5 U.S. territories, we understand that we are specifically positioned to be able to do a number of different things. And primarily what we want to do is we want to provide the CMEs and continuing medical education trainings and continuing nursing education trainings and information. That is going to be the work that we're going to be doing, as well as some policy work as well. So I'm going to be doing some state-based policy and legislative affairs work in NASAD moving forward. The conversation around what we can be doing around pushing LGBT competencies within state legislatures. So Washington, D.C. recently passed a bill that said that if you are going to be a medical provider within the district, that you have to have X number of cultural competency credits in order to maintain your license. So thinking about policy ways, things that we can do from a policy perspective to kind of usher along that competency. I mean, I don't typically use the word, but that's kind of what the legislation was centered around. And then the trainings and facilitations for the continuing medical education and the continuing nursing education, that's the work that we're going to be doing. Now, if you would like to have a conversation with NASAD about how we can be facilitators of bringing in health departments and other providers to have conversations, because we understand that health department knowledge is it's great. It's very specific. You all are on the ground, and you all are doing a lot of the work, and that perspective could be helpful for broader providers. So I think that if there's an opportunity for us to convene health departments and providers, general providers, and that could be a conversation that we have, and that could be a conversation that we have with the Virginia Health Department and other health departments, if that's something that you all are considering within your jurisdiction.
That sounds great, Justin.
No, thank you so much for your question. I'm going to try to answer the remainder of the questions. So I see Nestor you have your hand raised. If you would like to go ahead and speak, please press *7 and we will address your question.
Yes, hi. I think you touched on this slightly, but I wanted to kind of ask you to reiterate or perhaps get more into depth about what sort of metrics would you associate this approach with? I mean, what specific or most appropriate outcomes would you see? Would you see increased testing, increased engagement into PrEP, or just increased utilization of medical care? What sort of metrics would you look into?
So I think there is an evaluative piece, and admittedly what I'm working on for the curriculum is the how-to guide and how to put it together so I could put on the run of show for this. And Blake, who just stepped out, is working on the evaluation piece since he has a research and evaluation background. I do know that there is a research and evaluation background, research and evaluative piece written into each and every workshop. And I think that the initial goal is increased health literacy and increased testing. I think that those are the two goals that we primarily have for metrics moving forward. I think that that's in flux. Like I said, we are not going to be debuting this until July. So I think that the team is actively working on what some of the outcomes are, or what we have ideally what some of the outcomes would be for this product and project. But I think that initially increased health literacy and increased HIV testing are the optimal goals initially, to answer your question.
Hey, Cynthia, what's up?
So thank you so much for your question, Nestor. I'm seeing there's a lot of stuff popping up in the bottom. So Gloria.
Yes, I will. I'm going to have to send everything to you now.
So John Michelle, there's a question around, do you have any plans to include Black trans men who identify as gay, bisexual, or transgender loving? And for everybody who's asked
we'll
questions.
Talk before that date. I just want to give you a couple heads up about some other stuff, but I'll talk to you before that date.
Hey, so if we have individuals that have spoken already, I think what I'm going to do is mute all.
The conference has been muted.
So to answer your question, Jean-Michel, there's actually trans individuals that are involved in this project. To answer your question, I think it's specifically the spirituality conversation, spirituality episode, and the mental health episode, and the religious episode. So we have an individual who is of the trans experience and identifies as a trans man, and we felt that it was very important for us to incorporate them into the conversation. We admittedly are actively working as an organization to figure out how we are going to better address the needs of trans individuals. And that's something that we're actively working on a day-to-day basis. But to answer your question, yes, we do have plans of including trans individuals within this series. We have an individual who is trans who will be on a couple of the episodes. And moving forward, who knows how this turns out. If this is something that's robust and people enjoy, moving forward, we may have an additional 6 to 12 episodes. So there could be an opportunity to have broader conversations and broader dialogue from there about a number of different things, including the trans experience. And I want to answer any additional questions that individuals may have. I think that we've answered all the questions that have come up in the chat box. Yes, the answer to your question is the videos will be available for free, so we won't be charging anybody anything, whether that's the CNEs, the CNEs, or the curriculum. All of this will be available for download at the click of a finger. So it will be free, and we will hope to seek future funding for this product and project in the future so that it can remain free. But yes, to answer your question, everything will be free and it will be available to everyone's use, and we have a very aggressive dissemination strategy to get this information out. So I have full trust and faith that everybody will be able to have access to this. So I think that we are a little bit over time, unless we have any additional questions in the chat box. I think that I kind of answered everybody's question, everyone who had their hands raised. I'll answer all the questions in the chat box. I want to thank you all so much for your time, so much for your energy. I can definitely feel it through the questions that are coming up in the chat box. So Gloria Sims has a question. When discussing relationships, will the discussion regarding MSM and the women they love be discussed from a sexual relationship be discussed? So are we talking about the women that they love and if individuals are bisexual, or the women that they love such as like parents? Because I know that there's definitely a conversation about mothers and the important role that mothers has played. But if I'm remembering correctly, we shot these videos so long ago. We shot the videos back in June of last year. I can't remember if anything's discussed about sexual relationship with women. Admittedly, I do believe that all of us are pretty much out and kind of proud. And we originally wanted to have someone that wasn't necessarily as out or someone who considered themselves bisexual to be a member of the cast, but admittedly it was kind of hard to get an individual to come and be on screen and talk about their sexual proclivities without fear of judgment or fear of it being seen by their broader network. So I think that the original 6 videos are specific for the Black MSM experience and the trans man experience. Moving forward, I probably won't be involved in the future videos. I mean, you won't see my face probably in the future because it was a very scary experience to be shot on screen, and it's an even scarier experience to see those videos play out. But in the future, I think that there's more than enough opportunities for us to have tons of conversations. I would like to see this be something that's picked up by maybe a larger network, something that can have very, very broad reach. So moving forward, I will keep all of these topics and questions in mind as we're developing the future of the web series. And with that, I want to say thank you all so much for your time. I'm so sorry for taking an additional 4 minutes of your time. And if you all have any additional questions, please feel free to email me and reach out at jrush@nasad.org. And I want to thank you again, and I hope that you all have a fabulous day. Bye-bye.